The future is not like Mount Everest waiting for us to arrive and climb. The future is much more like the Great North Eastern Railway, something we imagine, plan and build. The future of healthcare is something you have to imagine, plan and build. If you don't do it, other people will. And another very encouraging thing about the future is, in the words of William Gibson, a famous writer, the future is here, it's just not evenly distributed. In looking at the future, now I'm going to tell you how I see the future, and you're part of making the future with what you're discussing at the conference today. It's also helpful to look at the past. And the first slide shows that we are at the end now of the second healthcare revolution. The first healthcare revolution, like the first industrial revolution, which created the steam engine, is based on common sense, empiricism. The second healthcare revolution, like the second industrial revolution, which gave us computers and airplanes, was based on high science. And you can see here in the handout the achievements of the second healthcare revolution, including antibiotics, coronary bypass grafts and stents. I'm very sorry I'm not with you today, but I had a stent about 3 months ago, and I'm currently on a course about antibiotics. I've been brought up in Glasgow, so I get bronchitis, and antibiotics are wonderful things, but I'm just not able to be with you. So the second industrial revolution and the second healthcare revolution have been fantastic. I almost certainly would be dead if it were not for it. Fantastic. But if you look at the next slide, you'll see that at the end of this fantastic era of progress, every healthcare service in the world, every one, faces the same 5 problems. Failure to prevent disease, inequity, harm, variations in outcome, and waste of resources. And if you look at the little diagram at the foot, you'll see that the world is going to change. And we need to think of a world in which there is no more resources, and we have to exist with a lot less carbon. The third industrial revolution is already with us, so says Manuel Castells. And so is the third healthcare revolution. And the third healthcare revolution, like the third industrial revolution, is driven by these 3 forces illustrated in the Venn diagram: citizens, knowledge, and the smartphone. You don't even talk about the internet anymore. The world has changed and is changing, and patients will be using this technology. We are, in the first time, we're in a world in which there are now more smart devices than there are people. There are 9 million iPads and phones, and many of them, as some of you will know, are in Africa and India and so-called poor countries. So, this revolution, I'm going to tell a little bit about certain aspects of the revolution. And in doing so, I find it helpful to think that we're moving from what I think of as the square peg to the round peg. Namely, the health service of the 20th century was perfect for the 20th century. A century in which we were vitally impressed with benefits of healthcare and which resources were growing. But it's a square peg for the 21st century. And the diagram of the square and the circle that you see before you is my picture of the paradigm shift that's taking place. There may be other things that you would like to add to this, and it's a good topic for discussion if there's any time. This is a diagram that's been prepared in discussion with about 40 or 50 clinical groups over the last year. So I'm sure you can think of some other things. Paradigm shift. And I'm going to speak briefly about 3 aspects of the paradigm shift. One is the move from quality and safety to value. Now, I find it helpful to think of the health service as being summarised in a single term. From 1948, that term was free. That was all that mattered. About 1972, Archie Cochrane published a book called Effectiveness and Efficiency. And effectiveness became the dominant paradigm, along with evidence-based decision-making. In the 1990s, it became cost effectiveness. And for the last 10 years, it's been quality and safety. And rightly so. But for the next 40 years, the dominant paradigm will be value. Now, what do we mean by the word value? Well, there are two types of meaning of the word value. One is what you would call the moral meaning. We value diversity, we value equality. The second is the economic meaning, and that's the one I'm going to use. And it also has two types of meaning. One, illustrated by these pie charts and the diagram in front of you, is allocative efficiency. Have we allocated the money in the right way to cancer, to respiratory disease, or to children and old people? And in the 20th century, we allocated more money, and that money was used either for osteoarthritis or for rheumatoid arthritis. In the 21st century, there won't be more money in that sense. So people will have to do allocations within the individual program budget. That's what we call allocative efficiency, allocative value. But there's also technical value, and the next PowerPoint shows you a formula. Value is the relationship of outcomes to costs. Outcomes is the net result of good outcomes minus bad outcomes. And good outcomes, of course, are influenced by quality and evidence-based decision making, so they're still important, as are bad outcomes and safety measures. But it's important to remember that costs are not simply money. The cost is the opportunity lost. The cost, another way of expressing this formula I've shown you, is that the cost could be expressed in terms of time, the time of clinicians, the time of patients, and in terms of carbon. Now the list on the next PowerPoint shows you examples of lower value activity. Obviously, if there's evidence that somebody does more harm than good, it's of low value, but there's not much of that about. Much more common is the way in which we see innovation taking place, but not in a context which will allow us to measure its value. And point 3 in this presentation, on this slide, is that something is of lower value if you get more value by giving it to another group of patients. You see, in the last 40 years, we've worked on the principle that more is always better. But for the next 30 years, we're working the principle that more is not necessarily better. And I'll just show you something these ideas developed by Avedis Donabedian. Firstly, if you look at the graph showing the law of diminishing returns, as you put more money into healthcare, first of all the benefits go up steeply and then they flatten off. Unfortunately, as the next graph shows you, the harm of healthcare goes up in a straight line. So the relationship between benefits to harm changes, and there's a point of optimality. That's what we mean by a value assessment. This affects individuals too. The arrow diagram shows the model we've used over the years about evidence-based decision making. There's the evidence, the condition of this patient, which the clinician has to judge, and the values of this patient. Now, you see, as we give more healthcare to people, if you look at the diagram with the two lines in it, as you provide more intervention, you treat people who are less severely affected. For the people who are less severely affected, the probability of benefit is the same, but the size of the benefit is smaller. But the probability of the size of harm is the same. So the offer is different. And for this reason, we're in a way doing simulated decision making. We're offering decision aids to patients considering elective surgery. So the little cover sheet I've shown you is the book I've created called How to Get Better Value Healthcare. That's the value paradigm. The second shift is the systems paradigm. Now here are some systems questions that I raised with people when I was in South England a few weeks ago. And you could apply these to wherever you are in the country. Is care for X better in A or in B? We don't know. We tell if it's better quality, but not better value. And here's the language of the 21st century. It's in the next little PowerPoint. Systems, networks, pathways. And we're starting to run workshops now where we ban the use of the words primary and secondary, acute and community, and we only allow system, network, pathway. Outpatients is banned too, completely. System, network, pathway. A system is a set of activities with a common set of objectives and an annual report. And the grid below shows a picture of a system. Objectives, criteria and standards. And there are different levels of standards, as you know from your quality work. Systems are delivered by networks. The picture of the hierarchy represents the 20th century. Professor, consultant, general practitioner. The 21st century, professor, consultant, GP, pharmacist, patient. The patient is as important as the professor. It's a network. We're also talking a lot about population medicine or population surgery. And here's an example. The big blob shows what Dr. Jones is dealing with. She's a respiratory physician in Derby. I don't know if she exists, but it's an illustration for you. And last year she was fantastic. She treated 346 patients. But Dr. Jones, how many people are there in South Derbyshire with bronchitis? We'd like you to know. And the answer is about 1,000. And she immediately finds 100 of them who would really benefit from coming to her clinic. But, Dr. Jones, there is no more money. We don't want you to expand your clinic. We want you to look after the population, to work with GPs and lead the COPD network for South Derbyshire. And the PowerPoint with the list of duties shows you the sort of things we'd want Dr. Jones to do. To get to know the name of all the pharmacists. To set up a system for finding new GPs when they come to South Derbyshire so they know what she can offer and, even more important, what's inappropriate. And to produce an annual report. So we get competition between systems for pride. And this is summarised in our little systems book, the cover of which is shown you here. Just to finish, we now need to think of another paradigm shift to the culture paradigm. Here, the two triangles show the way up which I think about organisations. There's a people, there's professionals, patients, the public, and then there's the organisation itself. Structure doesn't matter. Every health service in the world has the same problems with different structures. Systems are important, as I've said, and culture is important. And here in the next slide is the definition of culture by the guru Edgar Schein. It's the shared tacit assumptions of a group, a hospital ward or a health centre or a hospital, that it's learned in coping with external threats and dealing with internal relationships. And leadership, and you are part of the leadership of the health service, leadership and culture are interwoven. One way in which we influence culture, and we do this through Better Value Healthcare, is by helping you get common meaning of the terms that are used. So if we were to ask everybody in England or everybody in Kent or everybody in London to write down what they meant by the common terms listed in the PowerPoint, like equity or quality, what would they write down? The answer is you'd all write something different. Well, as I say to chief executives, how can you manage an organisation if people don't have a common language? So what we do is we deliver podcasts. Here's one on judgment, illustrated in the PowerPoint. Here's one, a book review on the wonderful Avedis Donabedian, whose name I mentioned. And you can see examples of these at www.ocht-foundations.net. The final picture is of ants. You see, for the last 50 years, we've tried to manage complex health problems by either the bureaucracy or the market. And neither works. You have to have a bureaucracy. The markets get some part to play in buying equipment, for example, developing new simulation equipment. But ants work as a complex adaptive system. We have to work together, not for the well-being of the individual professional, but for the well-being of the colony, of the population. Ants are the most successful species on Earth. They're adaptable, they can survive where we can't survive, they solve problems. So we need to think a little bit more about living like ants. I'm very sorry I can't be with you. I've highlighted 3 big paradigm shifts Simulation is another. Remember, we are in a new age now in which there are more smartphones and iPads than there are human beings on the planet